Hello and welcome to our Every Beat Counts Healthy Living and Lifestyles Dialogue. I'm really pleased to welcome Dr. Manish Saxena. Manish, how are you?
I'm great. Thanks.
Thank you for joining us. Could you tell us a bit about your background and your role?
Sure, Rudy. Thank you. So I'm Dr. Manish Saxena. I'm a cardiovascular physician and hypertension specialist at St. Barts Hospital in London. And I'm also Deputy Director for Research for Barts Trust and Queen Mary University, London. So I'm an active researcher. I've done a few research studies in cardiology and metabolic medicine at Barts Health NHS Trust.
Excellent. So we're looking forward to hearing your presentation if you'd like to go ahead.
Thanks, Rudy. So one of the most famous sons from Barts Hospital is William Harvey, and he was the first man to describe human circulation. And we are still very passionate about treating diseases of circulation at Barts Hospital. And as we all are growing older, we live longer as well. And we see that life expectancy is increasing. But the healthy life expectancy is not matching the healthy life expectancy. So even though we are living longer, but we are not that healthy. And the whole idea of working with patients in NHS in research is to make them more healthy so that they enjoy a healthy life in the future. We know that cardiovascular diseases such as heart attacks, strokes, they are the leading causes of deaths globally. Almost 1 in 3 people die because of cardiovascular diseases such as heart attacks and strokes. Even in the UK, 1 in 4 deaths are attributed to cardiovascular diseases. It poses a big burden on our health economy. And that is why we want everybody to be healthy so that we reduce this burden on our healthcare system. And there are different types of cardiovascular diseases we look at every day in patients, whether it's heart attacks, strokes, kidney problems, heart failure. But all these things, they also lead to vascular dementia and some of the complications of high blood pressure. And when we work with patients every day in clinics, we look at all these risk factors in patients. Some of them are non-modifiable factors. You can't change them. So some of the common ones are, say, for example, age. So as we grow older, our risk of getting these diseases, they increase. Gender, like males, they have a higher risk compared to females till they reach their menopause. And then after menopause, their risk is similar to males after a few years. People who have strong family history of heart attacks, strokes, you can't change it. It's a non-modifiable factor. Certain ethnicities, they carry a higher disease burden. Say, for example, South Asians like me or Afro-Caribbean people, we have a higher disease burden of these diseases because we are genetically at a higher risk. And then people who had a previous history of these diseases as well, if you had one heart attack, your risk of next heart attack is much higher. But then there are some very important modifiable risk factors, and 2 most important risk factors are high blood pressure, high cholesterol that we work on every day. But then some other very important modifiable risk factors. One of them is smoking, that if you stop smoking, your risk considerably goes down. But then people who have diabetes, their risk is much higher. People who are carrying extra weight, who are overweight, their risk is much higher. And then there's markers of inflammation. People who have inflammatory diseases, they have a higher cardiovascular risk. In terms of lifestyle, we work on things like smoking. So again, as I mentioned, if you stop smoking, your risk really improves or goes down. And then there are certain lifestyle factors that like diet, exercise, stress, sleep. We'll look at these. Some of these are very, very important lifestyle factors in cardiovascular diseases. But then there are certain social factors as well, which can increase the risk, such as social deprivation. People who don't have access to good health care, their risk is much higher. Environment, pollution, they are again very important risk factors. A recent big study from UK Biobank showed that people who are living closer to polluted streets, their size of the heart was slightly bigger. So pollution plays a very important role in the risk of cardiovascular diseases as well. And why do we talk so much about hypertension? Because with time, the prevalence of hypertension has really increased. There are almost 1,400 million people globally with high blood pressure. Even in the UK, almost 1 in 3 to 1 in 4 people have high blood pressure. But the diagnosis, treatment, and control rates, they still remain very, very poor. Many of the patients, 40% of the patients almost, they don't know that they suffer from high blood pressure. They're not never been diagnosed. And even patients who we diagnose, we are not treating them to achieve a good blood pressure control. So we really need to have a better strategy towards treating blood pressure, because it is one of the most important modifiable risk factors. And even though we know the benefits of treating blood pressure, we know that if we reduce of the upper blood pressure called the systolic blood pressure by 10 millimeters mercury, it reduces cardiovascular events by almost 20%. And the biggest benefit we see is in heart reduction of risk of heart failure and strokes. So the evidence is very, very clear. And not just the amount of blood pressure reduction, what we call quantitative control, some of the qualitative aspects of blood pressure control are very important as well. We know that patients' nighttime pressures are very, very important in predicting their risk. And evidence is very clear on the right that if patients, even if they have normal blood pressure, but if they are not dropping their blood pressure at nighttime with sleep, as most patients do, the risk is much higher, which again shows the quality and quantity of sleep as well. That's quality and quantity of sleep is very, very important, because that's the time when pressure should go down and body in a way recoups itself. And that again contributes towards reducing risk of heart attacks and strokes. But then post-COVID, there's a lot of focus on digital technologies, wearable devices, health technologies. And the whole idea is to monitor patients more closely, better monitoring, so that we can deploy more, we can be more aggressive in treating patients. And we know that some of these factors like better or strict blood pressure control, reducing the blood pressure variability, healthy nocturnal dip at night time, and blood pressure, they all contribute towards cardiovascular protection in patients. And many of the new strategies, new therapies coming on, they also target these risk factors. And just recently, the International Society of Hypertension, it showed this very important publication about lifestyle and diet. And some of the things that organizations like British Heart Foundation, they have been advising people for decades now about maintaining healthy weight, reducing sedentary behavior, sedentary lifestyle, engaging with more aerobic exercises. There's more focus on engaging in dynamic resistance exercises as well. They all contribute towards a more healthier weight and reduce cardiovascular risk. If you looked at food and drinks, one of the most important risk factors is salt intake. And UK guidelines says that we should all be eating less than 5 to 6 grams. But if you have blood pressure, you should be eating less than maybe 4 grams, which is less than almost 1 teaspoonful. So eating 5 portions of fruits and veggies every day, having more lean protein, less salt in our diet, all these things, reducing our sugar intake as well, increasing our fiber intake in diet, they again lead to much healthier cardiovascular health. But then this time, for the first time, they have acknowledged the significance of some of the things about sleep. So 7 to 8 hours of good quality sleep every day. One of the big elephants in the room that contributes to high blood pressure is excessive stress. So doing things like meditation, mindfulness, yoga, exercise to cut down that stress level, listening to music every day if you find it relaxing. They are some of the really important things, besides other things like reducing smoking or stopping smoking, limiting exposure to pollution, and maybe using some more digital wearable technologies, again, to provide more data based on which clinicians can make better decisions for you. But this is the first time that International Society of Hypertension has acknowledged a big study looking at just diet and lifestyle, which can make a big difference to almost every patient in everyday life. But then as part of our research, we know that research improves patient outcomes we know that research can really reduce the risk of heart attacks and strokes. We can identify high-risk patients much earlier, and then we can get them the right therapies much earlier as well. So we are very active in research. The challenge in research is also about making it all inclusive so that it's available for everyone. We want to make research population more diverse because we want to evaluate the effect of different therapies in all ethnicities, all ages, males and females. And even though it can be challenging, there can be some trust issues in getting into research. And that is why we want to engage with patients in the community through established trustworthy relationships like, say, research engagement network, to engage with participants, share the information about existing research so that they can consider the options which are available for them. So at Barts, I have been heavily involved in developing some of these digital technologies, wearable devices, and one of the technologies we work and we are starting a big study is developing this smartphone app. And just looking in this app for 30 seconds, this can calculate your blood pressure. But the whole challenge with these technologies is to make them more accurate across different blood pressure ranges, different skin tones, so that it works for everyone. And it can be, if it's successful and if it's really accurate, it can be an amazing tool to monitor blood pressure in patients in the community. And this technology that we work on, their idea is to turn every device on this planet into a self-monitoring healthcare platform, because now everybody has a smartphone, which can really contribute towards health management as well. We saw that if we improve blood pressure control, it makes a big difference in improving cardiovascular risk, reducing heart attacks and strokes. And what we see is that in spite of really good therapies out there, patients, they are not well controlled, or patients want to reduce their medication burden. And that is why we are heavily engaged in developing novel therapies. So one of the therapies I'm heavily involved as a UK lead is developing these 6-monthly injections for blood pressure, because one of the key proteins in the body in blood pressure regulation is angiotensinogen coming from our liver. And with these new RNA interference drugs, they are a very promising class of drugs which can target any protein in the body. So this drug, zilebesiran, can block this production of this protein angiotensinogen, which can lead to very clinically meaningful and significant blood pressure reductions. We have done two studies in the past. We are running a third study, and early next year, we'll be running a big outcome study evaluating its effects in reducing heart attacks and strokes. So it's a great therapy for the future in treating blood pressure. Similarly, there's another very interesting class of drugs called natriuretic peptide receptor agonist. Again, there are 4 weekly injections under the skin, and they have amazing potential in treating blood pressure, heart failure, patients with kidney problems. We have just finished a big study with them, and we are about to start another big study with this drug, which can again be a game changer in treating blood pressure. Recently, there's a lot of focus on this hormone in the body called aldosterone, which leads to salt and water retention in the body. And aldosterone also leads to bad things in the body like fibrosis, oxidative stress, inflammation, and it leads to damage to our heart, to our blood vessels. So there are new class of drugs coming on called aldose synthase inhibitors, which can block most of the effects of this hormone by blocking its production. And we are running some big studies in high blood pressure, kidney problems, heart failure. So these are great studies to show the benefit by blocking this hormone. How do we improve patient outcomes for the future? One of the other really big factors for heart attacks and strokes is cholesterol. And we work on various different therapies targeting different elements of bad cholesterol, such as bad cholesterol, what we call low density lipoprotein cholesterol, or LDLC. Recently, there's much more awareness and interest in this another risk factor called lipoprotein A, which is genetically transmitted. And we know that almost 20% of the population has raised LPA, which is not affected by diet and lifestyle, but it's transmitted genetically. And even though it's part of European guidelines now that every patient should get it checked once in their lifetime, but still health organizations have limited capacity to test for it. But we have been working on 2-3 big therapies treating LPA and showing the benefits in reducing heart attacks and strokes. Again, there's another very interesting class of drugs called oral PCSK9 inhibitors, which you can give orally to patients, which reduces your bad cholesterol almost by 40 to 50%, leading to heart reduction in heart attacks and stroke. So there's some big studies going on looking at high-risk patients who have raised high cholesterol. Then we are also part of some big studies looking at another bad fraction of fat in the blood called triglycerides. And there will be 2-3 studies looking at novel therapies reducing triglycerides, which will again reduce risk in patients as well. And then in preventive cardiology, one of the big pillars of preventive cardiology is inflammation. And there are certain therapies we are looking at reducing or targeting inflammation in patients to see how it improves outcomes in patients. So all these studies are great therapies. We want to engage with all kinds of patients, irrespective of patients' ethnicity, irrespective of patients' gender, because all these studies are good. But again, it's about a trustworthy relationship with patients so that patients feel comfortable coming into these research studies with us. So we are interested in seeing any patients who have risk factors like high blood pressure, diabetes, cholesterol, and if they're not doing well, we'll be very happy to see them. And then I'll be very happy to leave my contact details with Rudy and the Research Engagement Network. If any of the patients, they want to contact us directly, our team, and want to come and see it as Barts Hospital. Thank you. Thank you, Rudy.
Thank you very much for that, Manish. And just to confirm, telephone contact number is 020 788 23856. That's 0207 882 3856. And if you want to send an email, it's m.saxena, SAXENA, at QMUL.ac.UK. That's m.saxena at QMUL.ac.UK. So thank you very much for that most enlightening presentation, Dr. Manish, and look forward to seeing and talking to you again soon. Thank you.
Thank you, Rudy.